the inguinal ligament, and of course the pelvic bones. And it consists of skin and subcutaneous tissue, superficial fascia, and is composed of fat, muscles, deep fascia, abdominal fascia, and we mentioned in fat, and parietal peritoneum. And the skin attaches loosely to subcutaneous tissue, but at the umbilicals, where it is very attached firmly. Usually at the anterolateral wall consists of three musculotendinous layers, and where it has fibers running in different directions. Three plate structures similar to the intercostal spaces in the thorax. The fascia of the anterolateral abdominal wall says that subcutaneous tissue over most of the wall is a layer connective tissue containing amounts of fat. When the person or when the morbid obesity, the fat is augmented, right, is thicker, making some sort of a sagging folds. In the inferior part of the wall, this which are mentioned, the tissue which is in the subcutaneous is composed of two layers, a fatty, which is superficial layer, right, which receives another name, which is a Camper's fascia, and a membranous, which is a deep layer, which receives the name of Scarpa's fascia, right. Take a look in your atlas. The abdominal contents undisturbed layers of anterolateral abdominal wall, where you see clear the Hasselblatt's vein, the thoracic duct, the dissecting thoracic aorta, the esophagus, pericardial sac, where you see the hyphoid process, where you see the costal diaphragmatic recess, the gallbladder, the abdominal wall, the iliac crest, which is the pelvic bone, the external oblique, the internal oblique, the transverse abdominal muscle. And also take a look how the floor of the abdomen, right, is the rectus abdominis, the inguinal ligaments, right. The layer of deep fascia invests the external oblique and cannot be separated from this muscle. And the deep fascia in the abdomen is very thin in the abdomen. And it's represented only by the epimysium, which is a fiber sheet of the most superficial muscle, very firm and membranous sheet, the transversalis fascia, which lines most of the abdominal wall. This fascia layer covers deep surfaces of transverse oblique muscle, left transversus abdominis, and its aponeurosis, the right and left sides of the fascia continually deep to the linea alba. The parietal peritoneum internal to the transversalis fascia separates from it by a variable amount of 5 muscles in the anterolateral abdominal wall. Take a look at the atlas, in your atlas, right? And 3 flat muscles and 2 vertical muscles. These attachments and the innervation and their main action will be found along your tables, right? Where you can see how they work, right? Take a look at the tables to see, right, all the actions of these muscles. We're going to talk about the external oblique, which is a superficial muscle arising from the middle and lower rib by muscular lip. Interdigitates with those observans anterior. A pectoral muscle, the fibers of external oblique pass underneath, which is inferomedially. Internal oblique, the intermediate muscle whose fibers run horizontally at the level of the anterior superior iliac spine, and its fibers run oblique upward above to this level and obliquely downward inferior to it. The transverse abdominal is innermost skull, and its fibers with exception of the inferior ones run usually transversomedially at the at 3 flat muscles and anteriorly in a strong sheet-like aponeurosis, and where these muscles interlace at the linea alba, left white line, and opposite side to form the tough aponeurotic tendinous sheath or rectus muscle. The rectus sheath, the interweaving of the aponeurosis in the rectus is the cushion sheath. It's not only from side to side, but from superficial to deep. The 2 vertical muscles anterolateral, the abdominal wall, are within the rectus sheath, the rectus abdominis and pyramidalis. The other contents of the rectus sheath are the superior and inferior epigastric arteries and veins, lymphatic vessels, and ventral primary rami of T7 through T12 nerves. This small triangular, the pyramidalis muscle that is absent in approximately from 19 through 21% of people, lies anteriorly to the inferior part of rectus abdominis, where it goes to attach to the anterior surface of the pubis and the anterior pubic ligament, ending in the linea alba, a fibrous band running a variable distance superior to the pubic symphysis the pyramidalis tenses the linea alba. The external oblique muscle is the largest and most superficial of the three fat anterolateral abdominal muscles. Its muscular part is the anterolateral part of the abdominal wall, and its aponeurosis to the anterior part. Fibers of external oblique runs inferior medially in the same direction as the fingers when the hands are in one side pockets. Attachments, nerve supply, and main actions. Take a look at your tables, right? How this innervation and irrigation comes along with this muscle, right? The muscle fiber passing medially, becoming aponeurotic at the mid-clavicular line, and forms a sheet of tendinous fibers decussating at the linea alba, medial to the pubic tubercle. The external oblique aponeurosis joins to the pubic crest. Inferiorly, the inferior margin of the external oblique aponeurosis becomes thicker and falls back on itself, where we call the inguinal ligament, which is a fibrous band extending between the anterior superior iliac spine and pubic tubercle. This ligament is not a free-standing structure. It folds back on itself, becoming incurved to form a through, which forms the floor of the inguinal canal. Fibers of the inguinal ligament goes upward to cross the linea alba and blend with the lower fibers of the contralateral aponeurosis, which is called reflected inguinal ligament. The internal oblique muscle intermediate of the three flat abdominal muscles. The internal oblique is the muscle sheet that fans out anteromedially, and where the fibers becomes aponeurotic and roughly the same mid-clavicular line as the external oblique, and participate in the formation of the rectus sheet. The inferior aponeurotic fiber of the internal oblique arc over the spermatic cord, and it passes through the inguinal canal. The fibers descend posteriorly to superficial inguinal ring, touching the pubic crest and pecten pubis, a sharp ridge that is the continuation of the superior pubic ramus, the most inferior medial. Tendinous fibers of the internal oblique then gather together with the aponeurotic fibers of the more deeply placed transverse abdominal muscle to form the conjoint tendon, which turns inferiorly, attaching to the pubic crest and pecten pubis. Nerves and supplies and main actions. Take a look, please, in your tables and your atlas. And in between the internal oblique and transverse abdominal muscle is a neurovascular plane corresponding a similar plane in the intercostal second ilioinguinal nerve, branches of ventral ramus of L1 nerve, inferior intercostal, subcostal, and lumbar arteries. Deep circumflex iliac artery, a branch of the external iliac artery. The anterior part of abdominal wall, nerves and vessels, leave the neurovascular plane and goes in a more superficial plane. The transverse abdominal muscle, fibers of transverse abdominal muscle, innermost of the three flat abdominal muscles, run more or less transverso-medially, except for the inferior ones that run parallel to those of the internal oblique. Fibers of the transverse abdominal muscle end in aponeurosis, which contributes a deformation of the rectus sheath. Attachments and nerve supplies and main actions of this transverse abdominal muscle. Take a look at your table in your atlas. The rectus abdominis muscle, long, broad, strap-like muscle. Rectus abdominis is a vertical muscle of the anterior abdominal wall. The attachments, nerve supply, and main actions. Take a look at your table in your atlas. The pair rectus muscle is separated by the linea alba and lie close together inferiorly. Rectus abdominis is 3 times as wide superiorly as inferiorly. It is broad, thin superiorly, and narrow and thick inferiorly. The rectus abdominis is enclosed in the rectus sheath. It is anchored transversely by attachments to anterior layer of rectus sheath of 3 more tendinous intersections. In dense in muscular persons, the stretches of musculars between the tendinous intersection bulge outwards. The intersections indicating grooves in the skin between the muscular bulges occurs at levels of hyphoid process in umbilicals. The rectus sheath is a strong, incomplete fibrous compartment of rectus abdominis and pyramidalis muscle, formed by the decussation and interweaving of the aponeurosis of flat abdominal muscles. 2/3 superiorly of internal oblique aponeurosis splits in 2 layers, which is called also laminae, a laterally border of the rectus abdominis. At that level, one lamina passing anteriorly to the muscle and the other passing posterior to it. The anterior lamina joins the aponeurosis of the external oblique to form the anterior layer of the rectus sheath. The posterior lamina joins the aponeurosis of transverse abdominal muscles to form the posterior layer of the rectus sheath. Fibers anteriorly and posteriorly layers of sheaths interlace anteriorly median line to form a complex linea alba. At this level, take a look right in your atlas, the inguinal region of abdomen, right? And where the aponeurosis of the external oblique is partially cut, right? epigastric and the ilioinguinal nerves, which are branches of the first lumbar nerve. And take a look at the anterolateral abdominal wall deep dissection, right? And where the external oblique is excised on the right side, right? And the rectus abdominis also is excised, right? And the internal oblique is divided into left side, is divided on the left side. You can be able to find the anastomosis in between the superior and inferior epigastric arteries, which unites the arteries of the upper and lower limbs, right? The rectus sheath has an anterior layer consisting of interlaced aponeurosis of the external oblique and the anterior lamina of the internal oblique aponeurosis, and a posterior layer containing fused posterior laminae of internal oblique aponeurosis and transverse abdominal aponeurosis. The inferior one-fourth of this layer is deficient because the entire aponeurosis of all three calf muscles pass anteriorly to rectus abdominis, leaving the posterior surface of muscles in contact with the transversalis fascia, a crescentic line, which is also called the arcuate line, which demarks the transition of aponeurotic posterior wall of the sheath, which covers the superior 3/4 of the muscle, and transversalis fascia covering the inferior 1/4.